I think thank you very much for the invite. I'll request the organizers. I think they have the slides which they can share.
Yeah, sure.
Yeah, so it's there. So, thanks everybody for joining and giving me this opportunity. Um, there's not going to be really much here because it's going to be an overview and it's actually a bird's eye view. So I think, but we still need to revise because these are upcoming things and we need to understand which test we are going to advise and order, such as hereditary breast cancer, multigene tests, next generation sequencing, besides, of course, the traditional markers, which we are all aware of. So this is more of a overview and a little bit of future trends. So I'll rush through these slides. We're running late because I think there's a small panel as well later on. So, the biomarkers in cancer are very, very important because we need to have risk assessment, if they are important for screening and detection, for diagnostic purposes, for prognostication of the disease, prediction of efficacy to any particular treatment modality, and then of course for monitoring the disease, the recurrence, and the therapeutic response. So it's a very broad subject, that is the biomarkers. And in breast cancer, we do have a few of these markers on which we rely and base our treatment on. So we'll discuss that. Next, please. So it's a very heterogeneous disease affecting one anatomic site, and but phenotypically it can be extremely, extremely variable, and the outcomes can be, as you know, vary from few months to like 20 years, 30 years. So as I said, the biomarkers can help, in identifying such characteristics which could define whether a patient is having an aggressive disease or the patient has an indolent disease and likely to survive for a long period of time. Next, please. So these are the classical prognostic and predictive factors, which we understand. A T and M classification is the gold standard. And then, of course, the grade of the tumor, histological subtypes. I think the main thing is the ERPR HER2, which I'll come to, Ki67, vascular invasion, and tumor margins. So I think this is all old stuff which we are aware of. So, but this is what I'm going to, as I said, it's an overview. Next, please. So this is how we have evolved in kind of classifying the breast cancer subtypes from 1950s onwards, where you had the histopathology grading. Then came the molecular pathology in 80s, where ERPR, HER2/neu, Ki67, and all these other parameters which have not sort of stood the test of time were there initially. Then came the understanding of chromosomal abnormalities, which they could pick up depending upon the grade of the tumor. So now we are in the era of gene expression analysis, where you can identify the prognosis and the risk of metastasis and the recurrence score, which I'll allude to. And of course, type of the breast cancer, luminal A, B, B type, so which I'll just come to. And now from 2010 and the future trends will be dictated to some extent, by these molecular markers, where we have the hormonal therapy, as you heard, and the HER2/neu therapy, as you heard. And I think the era of PARP inhibitors is there. And then maybe in future we have stem cell inhibitors based on these parameters. So that's a little futuristic at this time. Next, please. So I think the current 2017 classification basically had tumor size, nodal involvement, and metastasis, which is the TNM classification. But 2018, there is an integrative prognostic classification, which also includes tumor grade, the ERPR, HER2/neu, metastasis, and the genomic expression profiling for the low risk. So this is how the various factors are getting incorporated to have integrative prognostic classification of breast cancer. Next. So these are again the similar kind of biomarkers, ERPR, HER2/neu, Ki67, which are predictive by and large. And these are the modalities, how these tests are to be done, IHC, IHC, IHC. and HER2 by IHC, and then by ISH if required to be done depending upon the IHC status. Next, please. So these are very basic, I think, at this time for us, because we are all doing this regularly. So this is the ERPR for EU. It is supposed to be 10%. For ASCO, it is 1%. So it basically are ER positive. 55 to 65% are PR positive. And as I said, ASCO takes 1%, and but some EU take 10% as the cutoff. Next, please. Next slide. So this is about the HER2 new. I think you're all aware, which is a part of the HER group of family. HER2 gene amplification is seen in around 20% of these cases of breast cancer. Next. So I think we all aware how to go for the testing of HER2 new. I think the next slide tells you that. Next, please. So I think IHC, FISH, and the bright field in situ hybridization by KISH or SISH are the tests to be performed. Next. And that's the summary slide. I'm not going to the details of this. If somebody is IHC 0 or 1 is considered negative, 3 is considered positive, and if somebody is equivocal, then you need to go for looking for HER2 gene amplification by FISH, and depending upon these, the signal and the copy number, one figures out whether the patient is eligible for HER2 new therapy. Next, please. So I think I'll skip these slides because they are very basic. Next. So Ki67 is another important parameter in which basically, you need to decide whether the patient is low Ki67 or high Ki67. So St. Gallen says 20%, some people say 30%. So these are, important markers in which you can, they can help you take a decision. Well, not truly take a decision, but at least prognosticate. Next. Between luminal A and B. That is the main crux of the Ki67. So based on these parameters, there are like 4 subtypes, as you all know: luminal A, B, basal-like, and HER2 enriched. So I think we all understand that luminal A is the low grade and ER positive and has an indolent behavior sensitive to hormonal therapy, whereas luminal B is similar, but the Ki67 is high and less sensitive to hormonal therapy than as compared to luminal A. Whereas basal-like is considered to be triple negative, highly aggressive tumor in response to chemo, and HER2 new is the one which is responsive to HER2 therapy and chemo. Next, please. So this is an important slide to show that younger the patient, higher are the chances of having a triple negative or a basal-like. And as you see in the elderly age group, the numbers are declining. And similarly, the luminal A is increasing as the age increases. So, and this is the normal-like as the age increases. So, which is more sensitive to the hormonal therapy. Next. So I think again we understand that the indolent nature and the responsiveness to the hormonal therapy for luminal A and stage-wise will give you better outcomes for HR positive and HER2 negative. However, of late the HER2 positive, because of the availability of newer agents, as you heard from Professor Giles, the things have improved in the HER2 setting. Next, please. So this is again to show the neoadjuvant chemotherapy, where you see the maximum benefit is for patients who are either triple negative or non-luminal HER2 positive. So I think these are 2 categories of patients where neoadjuvant chemotherapy in tumors which are more than 2.5 centimeters should be considered these days. And we need to convince the surgeons to allow us to do the neoadjuvant chemo. Next. So this is the locoregional recurrence by molecular subtype, which is the highest in triple negative, followed by HER2 positive patients, whereas luminal A has the lowest frequency of locoregional recurrence. So these are important biomarkers and important facts which we understand between these subtypes of breast cancer. Next, please. So I think we understand all this. Next, please. So now coming to the newer things which are emerging now, that nearly 5 to 10% are hereditary breast cancer, and BRCA1 and 2 constitute around 60% of the pathogenic variant in breast cancer, and small percentage would have P53 and P10, and rest are unknown. So these are important considerations now, because we have the availability of PARP inhibitors, which could target the BRCA1 2 pathogenic variants or potentially deleterious variants. Next, please. So this is basically to show that BRCA1 2 are the most common genes, but then the other genes are also important, like ATM or PALB2 and RAD 551D, etc. And they have variable penetrance, because these are the high penetrance genes. These are the moderate penetrance, and the lower one are the low penetrance genes. And these are the somatic mutations. And so PIK3C, as you heard from the professor, is, I think, the most important one at this point in time, because we have a new drug against this. ESR1 is acquired when patient is exposed to aromatase inhibitors and renders patients resistant to aromatase inhibitors. We do not have agents against, these. The trials are ongoing. I believe AKT1 is very high on the list for a triple negative subgroup of patients. So this is a ongoing research and evolving field to target somatic alterations and also germline alterations. This is very high agenda at this time. Next, please. So I think we all understand that patients who have personal history of breast cancer or family history of breast cancer, young age, triple negative, should go for these kind of germline mutation testing. Next, please. So I think this we all are aware. Anybody having a family history of pancreatic or ovarian cancer and prostate cancer should be subjected to BRCA1/2 analysis, so as to select out patients who could benefit in the metastatic disease for PARP inhibitor efficacy. Next, please. Okay, so I think there's a discussion whether one should go for single gene testing or a panel testing. I think both are available. So depending upon your choice, one can either go for BRCA1/2 testing, because that is where the drug is approved. But I think a lot of people employ multiple genes testing with the NGS panel, which is as good. The only thing I can suggest is, if either of these is negative, I think an MLPA should also be performed to rule out the large deletions or duplications, because they are missed usually in the PCR particularly, or NGS, but direct sequencing can pick up those deletions. So, I mean, MLPA is something to be considered if your NGS is negative. Next, please. So I think gene expression profiling has also come a long way now, because especially in patients who are hormone receptor positive and tumors less than 4 centimeters, should merit the gene expression profiling to look at the oncotype or memoprint. Next, please. So, these tests are available, and Oncotype DX and Memoprint are approved by NCCN and other guidelines for selection of chemo or not chemo, depending upon the risk scoring, which we are all aware. PAM and EndoPredict and Breast Cancer Index are available to us, but I think they need to be still validated at this point in time for the patient for or not for chemotherapy in the early hormone receptor breast cancer setting. Next, please. So I think this is, we're coming to liquid biopsy these days, because sometimes the tissue is not available. Like for patients with lung cancer, one liquid biopsies are becoming available, especially the international ones are available, which are more expensive. But from India, I think the work is ongoing. Especially for lung cancer, I think you can rely on. But for breast cancer, I think they still need to work to address the role of somatic mutations, particularly in liquid biopsies. You can do that first. If it is negative, then you still should rely on the tumor tissue. But I think breast cancer still, in India, at least from the Indian labs, I think there's a lag at this point in time. Next, please. So I think this is to sum up the ctDNA or the cfDNA. I think for breast cancer, we are behind. I mean, that is my assessment from whatever labs we have from our country. However, labs like Foundation One and Guardant, they do provide liquid biopsies, which are as effective as the tumor biopsy, but they're more expensive and therefore out of reach of common people for looking at the somatic mutations. So I think that's where we stand. But then the ddPCR, for example, for PIK3C would be available, and one can do that, for looking at PIK3C or just the RT-PCR for that matter, from the peripheral blood, if the tissue is not available for some reason. Next, please. So I think this is how things are evolving. That we have cancer stem cells, which give rise to basal or basoluminal or luminal, and basals are grade 3 and luminals are grade 1. Androgen receptor more common in basal or the triple negative. ERB2 is in between, and ERPR positivity in grade 1. And these are some of the IHC markers, CDK, CK5, 14, and 17. So the genetics are more unstable in the triple negative or basal type as compared to luminal. And then, of course, you have these 4 luminal types where chemotherapy works better in the basal and the ERB2 positive, whereas endocrine therapy works better in the luminal A and B. PARP inhibitors are more so in the basal type, and androgen receptor inhibitors would be there for especially for triple negative. And these are the stem cell inhibitors which become available may be working for all sorts of tumors. So I think we've come a long way, but as we know that this is a very, very heterogeneous disease, and we still need to understand the biology of the disease much better by way of doing these genomic analysis and targeting these genes as we identify. For example, P53 we know is abnormal in a lot of patients, but we have not been able to discover an agent which could, rectify P53. And similarly, P10 and so many other genes, as I showed you. So there's a lot of work going on, and a lot of more work needs to be done to identify the targets and target those genes successfully to achieve a control. Like as I said, AKT1 is a target which we have drugs against now. So I think we are evolving relatively rapidly in some areas. For example, HER2/neu, as you saw, deruxtecan and tucatinib are really wonder drugs, but they're so expensive at this point in time for HER2/neu. And but we have done exceedingly well for endocrine and HER2/neu. But I think triple negative is something where we are lagging behind, where we need to identify these targets so as. So I think we can stop there, uh, and we can have a discussion. I think Dr. Bapna is asking the question of current status of HER2 tumor. So I think, I don't know if Dr. Giles showed the data on the emerging the deruxtecan, which is successfully looking at low HER2/neu. So I think that again is a very rapidly evolving field where you are getting very promising preliminary data for HER2/neu tumors. But I think you're still waiting for some kind of approval from FDA and other bodies to incorporate such an agent into HER2/neu low tumors.